this is a case when, you know, I did a routine buccal surgery for a regmentogenous retinal detachment, scleral buccal surgery for a regmentogenous retinal detachment. But what happened after, you know, sometime for the recurrence, then I thought it's a young patient of not to do a vitrectomy, and there was a fish mouth opening, and the recurrence is because of that. So revision buckle was another process which has been, you know, we used to do earlier. But do we have any other technique of doing, you know, doing it in a different way? So what I did is I will show you. We did a needle drainage through the scleral buccal area, and then we did the laser to that area, and the retina is very well settled. Let's see it. So the chandelier, I have put the chandelier so that the whole surgery, we have this is the edited part, and you can make out that I was just trying to, this is the indentation first, and followed by here the needle is coming out through this in the subretinal part. Sorry, the video quality is not that great, but you can make out the needle was there. And then slowly my assistant was, you know, withdrawing the fluid, subretinal fluid. Gradually you can, yeah, this amount of the fluid has come out, and I can see the retina is very well settled. And in that area we have put initially one chandelier was put, and then later I made one more you know, sclerotomy to go and do the laser in that previous break area. So I thought that this is a simpler way we can handle this kind of recurrence when you have a you know, there is not much of PVR changes and then the early part, so you can get away with this. So a quick comment from others.
Very nice and innovative technique. And was there a buckle in place here earlier?
Yeah, yes, the buckle was in place. So the only tips I would like to share it here, and I think the only thing is that what I did, I had a metal depressor. So with that metal depressor, I just, you know, where I have the maximum amount of the fluid, so I went there, and with the with the metal depressor guide, 26 gauge needle, I have passed through it. So through the buckle, I have gone into the subretinal space and just taken it out.
RUPAK, this was a non-vitrectomized eye?
This is a non-vitrectomized eye.
It's a buckle eye.
It's a buckle die. This is a buckle die. So I just, you know, but it is very difficult otherwise also to go so deep through that buckle, you know, through that buckle area. I have penetrated through the buckle and then gone into choroid, sclera, choroid, and then subretinal space. So unless until you have a very good guide and indentation properly, then it is difficult.
26 gauge.
Jinal will just finish it up. Jinal will just 30 seconds.
Yes, no problem, sir.
26 gauge needle, Rupa?
Yeah, 26 gauge needle. It is with the 26 gauge needle, and because it's a more stouter needle.
It will be firm enough.
I think the
Dr. Ajay Arora sir has a guide for suprachoroidal injection. Maybe that can be modified for this particular kind of technique. Sir, your comments.
Yeah.
Yeah, so I was going to say that there are two things which can be done in such a situation. One is to use a suprachoroidal buckle, which I've been trying. If we can do it, we are not getting the right material. But obviously, this can easily be done with the same guide. You can go inside with a 30 gauge needle within the correct space, and you can actually connect it to your exclusion and aspiration.